How would those injections then, from what you described, and the anti-inflammatory and kind of, you say, not necessarily regenerating things, but maybe trying to aim towards reducing the rate of degeneration. How does that differ, though, from the standard things that people might be offered in terms of things like cortisone and steroid injections?
Yeah, so the two common injections that people do, and even currently do, and even I would do in my practice in certain situations, as you say, it's a steroid injection, hydrocortisone or depomedrone, or a hyaluronic acid injection. The steroid is purely working as a pain relieving injection. It's essentially reducing the level of inflammation, but it's not adding any sort of growth factors, any proteins, any anti-inflammatory cytokines. It's just reducing inflammation. And it can be quite good as a pain relieving injection, quite good for diagnostic purposes, quite good to get on acute flare-ups, synovitis, this sort of thing. But it doesn't have a prolonged effect. And also there is potential negative effects with it, where it can cause issues, particularly preceding joint replacement, lower the threshold of the immune system, infection, this kind of thing. Hyaluronic acid works obviously slightly differently. These are the building blocks of cartilage, the proteoglycans. But again, the evidence that's borne out, and this is over a good 10 to 15 years now, hasn't really shown much in the way of improvement. There are certain, products out there that have shown, reasonable data. And again, they're things that we use, but the effects generally are thought to last, no longer than really 6 months, if at all. So we tend to move away from those things, although they both, have their use in certain situations. The biologic agents work by effectively taking the body's own blood, spinning this down, releasing, or separating the platelets, which are considered the catalyst type cells, and then concentrating those cells and either injecting this back into the knee, or sometimes we do a technique where we double spin them, we break down those platelets to release the growth factors. And that's then injected back into the knee, really to act as an anti-inflammatory kind of medium, but also improve the actual proteoglycan, the matrix, the homeostasis of the knee. And in terms of, that would be the sort of first line, therapy for that sort of mild
PRP you're talking about first, yeah.
Yeah, PRP or platelet derived growth factor, those are the two kind of, when you double spin it, you're actually breaking the platelets down to release the growth factors, or the autologous protein solution. That's another name that people use. But yeah, essentially, PRP, platelet rich plasma, is the term we use. And that will be generally my sort of first line of treatment for patients with, mild, moderate arthritis. People do use it even in grade 3, grade 4 arthritis. But I think, it's one of those things where the earlier you recognize the problem, the better the outcomes are in terms of, when the symptoms first come on. When you've got grade 4 arthritis, there's other processes going on. So it's not surprising that the results aren't as good. And this is where the data is very skewed. When you interpret medical data, you're looking at a very mixed bag of picture. People are using it in all kind of cases and not stratifying it. And that's why you sometimes get this sort of negative, studies showing that, it has no effect, because possibly, their inclusion exclusion criteria haven't been robust enough.